Welcome to another episode of Article Reviews. We have Chris Massimini, Dr. Chris Massimini. Tell us a little bit about yourself, Chris.
I'm a physical therapist that's been practicing for 10 years in an outpatient setting. Strong interest in overhead throwing athlete injuries and sports injuries in general, but also really enjoy treating, just the average Joe, working man, senior citizen type, I like
Absolutely.
Variety.
Big Philly and Penn State fan, correct?
Correct. Mm-hmm.
All right.
Always got to support your alma mater.
Yeah, right. Philadelphia University.
Penn State. I went to Drexel for grad school, though. So.
Yep. Yeah. All right. Well, we will jump into the article now. The link for the article is below, as well as a little bio on Chris. So scroll down to see all that. The title of this article is Prevention of Shoulder Injuries in Overhead Athletes, a Science-Based Approach. That's by Ann Cools. The first bullet point we're going to talk about is, I'm just going to read off a couple things, and then we will dive in a little bit deeper with our own thoughts and how you can apply these within your treatment practice. So the article reads, in particular, glenohumeral internal rotation deficit, or GERD, rotator cuff strength imbalance, scapular dyskinesis, thoracic spine stiffness, and hyperkyphosis, lumbar core instability, and hip range of motion and strength deficits possibly create a cascade of injury as defined by Kibler, Lintner, and in overhead athletes. I think if you have all those, you're going to have some other issues too. It's just like, let's name everything in the book. Yeah, of course, you're going to have some issues.
Umbrellaing everything.
Yeah.
There.
Let's not forget anything. Trigger finger too should be listed in there. The article goes on, in order to create a scientific basis for the prevention of recurrent injuries in overhead athletes, 4 steps need to be undertaken. Risk factors for injury and re-injury need to be defined. Established risk factors may be used as return to play criteria with cutoff values based on normative databases. 3 would be these variables need to be measured using reliable, valid assessment tools and procedures. 4 is a preventative training program needs to be designed and implemented into training program of the athlete in order to prevent re-injury. The article continues, preseason reduced internal rotation range of motion, reduced total range of motion, a strength deficit in external rotators, and inadequate scapular position during clinical testing were shown to increase the risk of overuse chronic shoulder pain in these athletes.
Of course, external rotator weakness and that lack of a glenohumeral scapular rhythm properly by having your muscles be strong in both the rotator cuff and the scap stabilizers is of course going to alter mechanics, and I think this is the crux of trying to prevent injury is, when an overhead athlete, whether it be a pitcher or a volleyball player or swimmer, whatever, when their form suffers, that's when over time it's going to lead to injury.
Absolutely.
And I think it's a multifaceted approach other than what they're just saying, obviously predisposing factors, but, coaching has to be thrown in there too to make sure these athletes are getting the proper form and techniques down. Because if you don't have that, then that's going to create these bad behaviors and poor muscle contractions as well.
Absolutely. And you kind of run into like a chicken and the egg situation where is the form bad because tissues have shortened or there's weakness, or have tissues already shortened and weaknesses or muscle imbalances have developed, thus creating the bad form?
Exactly.
And these are things that
really matter because you should assess. And does it really matter because you should be assessing both?
Absolutely. And that's why it's kind of a multi-approach where you have in colleges and high schools, you'll have your athletic trainers. Hopefully you have a good relationship with your local PTs and as well as your coaches to establish that proper form. And they mentioned reduced internal rotation or reduced total range of motion. And what can often happen is you'll lose internal rotation, but you'll gain external rotation. Exactly. So we'll go on into the numbers that we're really looking at, but a little bit of internal rotation loss is okay in most cases. as long as you gain a little bit of external rotation. And that's usually what occurs in most overhead athletes: baseball, softball, tennis, and handball, those types of sports. It is hypothesized that the cumulative loads onto the posterior shoulder during the deceleration phase of the throwing motion cause microtrauma and scarring of these soft tissues. As a result, posterior capsule shortness possibly increases the risk for internal as well as subacromial impingement in the overhead athlete. So that's kind of what we were talking about, where if you're getting that tightness in the posterior capsule, you're going to lose some adduction. You might lose some internal rotation, and the stress placed on those can often be caused due to the lack of eccentric control in your external rotators.
Yeah.
So do you have any good exercises that you like athletes to use?
I mean, you can go a lot of different ways with that. I certainly enjoy, your band work,
Absolutely. It's such an easy tool to carry around, throw in your bag everywhere.
Exactly. And, and if you want to get all encompassing and throw in a single limb stance with that, especially for a baseball pitcher, I mean, that's more functional. And then you have those things like laying in a prone position with your arm abducted out 90 degrees, and you have a little bit of a medicine ball, drop it and try to,
Exactly.
Things like that. And, you find your athletes really like things like that because they're using a ball and catching and things like that, which is good.
But really eccentric is where you want to strengthen. Concentric would be more of your plyometrics. And that, they go over that in this article, but just to touch on that quickly, your lighter weight exercises, more plyometric wise, would be concentric, whereas your strengthening would be a little bit more eccentric.
And it is a tough exercise to think of when you think about it, because if you consider the velocity of the arm motion in an overhead thrower or a volleyball spiker, it's tough to mimic that in a Therex type
Absolutely.
situation, and that's where that load, I mean, that's the crux of the injury, when they're slowing down that velocity downward motion after release of a ball or after contact. It's a tough one to kind of figure out in the clinic to a certain extent.
I'm thinking that you'd be able to do something along the lines of, if you have a TheraBand here, you could grab onto it with both hands, use your non-dominant side to lift up, let go, and lower down. And that would be really in that end range where you're following through with the pitch.
Yeah, and that's a great point, almost incorporating a PNF pattern too.
But the ball catch is a great one. Where you would be lying prone, like you mentioned, with your arm out to the side, and you just drop the ball and catch it real quick.
And you got to make sure they're ready for those type of things too. And that's where the band exercise is a good starting point. Get a good strong base. And, I'm a big believer in, for every rotator cuff exercise, you should also incorporate a scapular stabilizer exercise, because the two work in tandem.
Absolutely. And if you're a big gym buff, a lot of people always work on their chest muscles. If you do a lot of bench or anything that is an internal rotator or an adductor, a good rule of thumb is for every one exercise you do of those, you do two to open your chest up and strengthen up that way.
Absolutely. And a lot of the athletes that you were discussing are those type of folks that really work the pecs and the biceps, and, and some of these other muscles go kind of ignored.
Absolutely. The article goes on to say there's a body of evidence showing an association between scapular dysfunction and shoulder pain, specifically in the overhead athlete. However, there's no consensus regarding the cause-consequence relationship between both clinical entities. They mention in the article that if there's an obvious issue, then with the shoulder blade, if you have a ton of scapular winging, or you're just not seeing that good scapular humeral rhythm, then that's something you want to address, certainly. And we're talking primarily inferior trapezius and serratus anterior to work on stabilizing that scapula better. So if you want to get back on the bench press, just pushing that weight up, just protracting your shoulders, rounding out, trying to hug that tree, and then bringing it back. No elbow bend. We're not bench pressing. We're not extending the shoulders back. It's just pushing out, rounding out, and coming right back.
With a good emphasis on speed control on the
Absolutely.
setback.
And then for the inferior trap, lying prone, you can do like a Superman, just working through that top 30 degrees of motion.
And even get them on the stability ball to do the whole T, Y, and I series. That way you're getting a core engagement as well.
Absolutely. And you can do more of those things with the bands as well. The band is really going to be your catch-all as long as you have the appropriate resistance for all those.
Form.
In addition to the more local risk factors mentioned above, more functional deficits might be risk factors for injury like faulty biomechanics, throwing fatigue, etc. And we kind of touched on that earlier, so I don't think we need to go over that again. You always need to keep track of both your form, tissue extensibility, tissue strength, muscular strength. In order to measure these variables, there is a need for functional testing in a throwing specific position. For instance, endurance tests of the shoulder into a throwing position, throwing distance, speed, and accuracy. However, with the exception of some tests mimicking shoulder function, like the seated medicine ball throw or the Y balance test for the upper limb, to date, no science-based functional test has been fully validated to determine risk factors for shoulder injury or return to play after injury. The Y balance test for the upper limb, or the upper quarter Y balance test, is something we talked about in the last session with Dr. Stephen Pete. And essentially that's just you have 3 arms of a PVC pipe with a wooden plate on each end, and you're stabilizing with you can do it on both sides. So you're going to stabilize with one arm and then slide that out as far as you can without falling over and measure those distances. And there is norms.
They had mentioned, the throwing distance, speed, accuracy, and throwing position. That's knowing when to pull the pitcher, when you start to see the faulty mechanics. And that's where having a good relationship with the coach and others is very, very, very important. Because, I think a pitch count to a certain extent is overrated because it really depends on the mechanics.
And the individual. If you have somebody who's not getting that degradation in their posterior capsule, then is it really that bad to leave them in an extra inning or two?
Mm-hmm. Or conversely, if you have someone, granted, you want them to throw 90 pitches and they're at 70 and you start to see some faulty mechanics.
Absolutely.
Would the right thing be to pull there? It goes both ways. It's all about the safety and mechanics.
Return to play criteria. There's no consensus in literature with respect to the cutoff values for internal range of motion, ranging from 18 up to 25 degrees depending on the study design and population. Now, the interesting thing, which obviously there's studies on this, but I've read contradicting studies, as they said, a 30-second hold for 3 repetitions of, say, like an adducted or a sleeper stretch, I think in this particular study, was not significantly different than mobilizations. So if you do like a posterior lateral joint mobs grade 3 and 4, there was improvement. It was better than the stretches, but not significantly enough from a clinical standpoint.
Mm-hmm. I'd say, speaking from a clinical standpoint, if you're treating that sort of tissue shortening, chances are if you're, doing your hands-on, you're going to issue both,
Oh, absolutely.
Manual treatment, and they're going to go home and you're going to instruct them to do the stretch multiple times a day. So, you should really be doing both.
I think the question there is, when you're developing the frequency, are you going to say 2 times, 3 times, 4 times a week? So that's kind of how you need to think about applying that with that knowledge to your practice. In view of maximal protection of the athlete, it is advised that side differences in internal rotation range of motion should be less than 18 degrees, and the difference in total range of motion should be no more than 5 degrees. So as we were talking about before, in the beginning of this article, we're kind of differentiating between internal rotation loss of motion as well as total rotation loss of motion. If your dominant arm has 18 degrees range of motion less than your non-dominant arm, that would be a cutoff criteria. And as well as if you measure total range of motion, external and internal, there should be at least 5 degrees more on the dominant arm. So as long as, like we mentioned before, as long as you gain in external rotation what you've lost in internal rotation in your dominant arm, everything's kosher. Now we get into how you're going to test these within your practice. I think some of these are pretty self-explanatory in terms of the range of motion. For internal and external, you're going to block the scapula using the plinth, so lying supine, check their internal and external rotation with the elbow bent to 90, shoulder abducted to 90, and the arm can be supported by a towel. A lot of people will test external rotation to the side and then a functional internal rotation or a functional external rotation if you're in your non-athletic population. But I definitely think you have to determine what their goal, everybody's goal is. So putting a jacket on.
For an athlete, you got to.
Yeah. Putting a jacket on, throwing a ball. In addition, horizontal adduction can be measured in the assessment of posterior capsule stiffness. It is advised that the measurement be performed with the shoulder at 90 degrees of flexion and horizontally adducted until the scapula starts moving laterally. While one investigator manually fixes the lateral border of the scapula and palpates the lateral movement of the scapula, the second moves the upper arm toward horizontal adduction and measures the angle between the upper arm and the vertical. Especially during evaluations, if you're in a private room, you're not always going to have a second pair of hands to hold down someone's scapula. So I think this is very doable on your own to just kind of get into that lat scapular area, press down, stabilize, isolate that movement as you adduct and get your motion from there. Now we're getting into rotator cuff strengthening. The article reads, in general, with respect to cutoff values, distinguishing a healthy shoulder from a shoulder at risk, an isokinetic external rotation, internal rotation ratio of 66% or an isometric ratio of 75% is advised, with general rotator cuff strength increase of 10% of the dominant throwing side compared to the non-dominant side. A lot of people out there do not have the electronic handheld dynamometers to really test that accurately. So I think most of us are going to be working with the manual handheld dynamometer with the 5 different positions. So you got to get creative with it a little bit. The main thing is that you are testing it the same every time. So if we're testing external rotation, you can get them into that position. You're going to stand behind them and stabilize their elbow with one arm and then push down on them towards 90 degrees. That's how this article says that you should do it. And I would agree. I think that's a good way. You could also educate them to not adduct at all. And just if they're going to give, it has to be into that internal rotation.
It's a good way to just assess the rotator cuff strength for sure. And I think you're right. That's a fine and good and clean way to do it. And as you get further along the program, it might not hurt to do the same test without the support.
Absolutely.
So you can watch to see what their shoulder does and their scapula does, because, obviously when they're going to spike that volleyball, they're not going to have someone holding their arm up so that they can isolate just the rotator cuff. So yes, but speaking from a more functional standpoint, I do have my concerns about just using that as the only test, obviously.
In view of the eccentric component of the function of the external rotators, the sport-specific exercises for overhead athletes should focus on 3 areas. 1, exercises that accentuate the eccentric phase and avoid the concentric phase in order to load the muscles based on eccentric capacity. We already talked about that. You want to strengthen eccentrically your external rotators. 2, slow exercises for absolute strength. Fast exercises for endurance and plyometric capacity. So when you have those heavy weights, make sure you're going slow. When you have a lighter weight, you can go a little bit faster. Endurance and plyometric capacity may be exercised using weight balls, exercises in which the patient is instructed to catch the ball we already referenced that, where they're dropping and then catching real quick. I think those balls are often 12 ounces, somewhere in that range.
You don't need a lot.
No. And you're doing repetitions of these. That's not where you're gaining your strength from. That's the plyometric aspect of it.
I usually do timed reps personally.
Okay.
Like 45 seconds, 5 times, or
Gotcha. And you're telling them as many as they can within 45 seconds?
Exactly. Yeah.
Perfect. Clinicians should be aware that some degree of scapular asymmetry may be normal in some athletes. It should not be considered automatically a pathological sign, but rather an adaptation to sports practice and extensive use of upper limb. And that's in single arm use, so pitchers, tennis players, predominantly, not swimmers, because any adaptation should be seen on both sides in swimmers. In summary, with respect to injury prevention as well as return to play after injury, the clinician should evaluate possible risk factors for injury in the shoulder, in particular, GERD, rotator cuff strength, and scapular performance, using a reliable assessment tools. In case abnormal findings are established, the intervention should focus on stretching of the posterior capsule, sleeper, strengthening of the posterior cuff, catch, and restoration of flexibility and muscle balance of the scapular muscles. So we have your presses and then your inferior trap, that little Superman exercise. And that pretty much sums it up. That's the article for you, ladies and gentlemen. I hope you enjoyed it. Any last words, Chris?
Nothing to add. Thanks for having me.
I really appreciate your time, and we'll see you in a couple weeks for the next one.
Sounds good.
See you, Chris.